I think we're on air. Hi, Morten. Hi. How's it going?
Hi, Richard. Very good. And yourself?
Yeah, yeah, all good, all good. Good to see you. And just so people know, where are you sort of coming in from?
I'm coming in from Aarhus, or just north of Aarhus, which is a small city in Denmark. Well, Denmark-wise, it's the second largest, but that doesn't say a lot. So a small city called the smallest big city in the world, since we do have a bit of cultural life and a lot of other stuff.
Yeah, and you,
Looking
and that's
looking
where
out,
you're
there's a bit
based.
snow as it is.
You've had a sprinkling of snow. Ooh,
Yeah, first this year.
yeah,
What about
nice.
yourself?
No, well, I'm down near Brighton, and it's a bit frosty this morning, but they did threaten snow, but we haven't had any. We had a bit of a dump a few weeks ago, which always causes mass chaos. And I guess people from Scandinavia, I see you sort of the wry smile, and I know you know the UK well, but the wry smile of we get some snow and everything kind of grinds to a halt, whereas to you guys it's just like, hey, this is the way it is.
Yeah, I think that might go for the Norwegians and the Swedes. We're still surprised every time there's a sprinkle of snow as well. So particularly on public transportation.
Is that like a childlike surprise, a sort of a glee, a kind of open the windows and
Yeah, not the sprinkles, but if you get that, wake up and it's truly white in the morning, does butterflies start to spring up and you're like, should I put on my gloves and go out and toss a snowball or whatever?
nice,
Yeah, I
nice.
still get excited about snow, although I do
Good.
do appreciate the heat. But sitting inside or just going outside for a brief moment, coming back in and have a hot chocolate or something,
Mm,
really lovely.
yeah. Now we're talking about, and I'm probably going to pronounce this wrong. Hygge, Hygge,
Hygge.
Hygge,
Yeah, that's it.
Hygge.
Exactly.
Yeah,
It's
yeah.
what
I
we
mean, I mean,
like.
when you think about that word, I mean, what does that do to you inside?
Well, essentially, it gets you fat, doesn't it? there's a there's a combination of sitting together, chatting, and eating that is combined into the word. At least the way I see it. So hygge is. So I think the direct translation would be something like coziness, right? But you would everyone knows what it is, but I think everyone has their own definition of it. Um, Unlike many other things, or maybe just like any other thing. I don't know.
Yeah, well, you're getting me thinking there, because obviously the one of our commonalities is pain, and immediately I was then thinking, okay, yeah, hygge. Everyone's got their own sort of version of it, and I kind of wonder if because there are a lot of books came out over here and probably all over the world, you know, describing how you can do it, and I just wonder if you actually can do it anywhere other than where you are. Really, can you really do it, or is it specific to where you are?
Um, no, it's not. But you have to feel comfortable. So if I go and visit my mate Tim in London, or now he's down in Kent, then I could definitely feel the hygge down there because I feel comfortable. I love being with the people. I like being in the surroundings. We have a similar sort of approach to, you can put your feet up on the couch and we want a cold beer or whatever. So as long as the context is there, and I think it's, at least to me, it's more about the people I meet
Yeah,
than than the place. But the context does matter.
yeah, yeah,
Again, it
and I
sounds
guess
like
you're
we're talking
brilliant,
about
aren't
pain,
you?
doesn't it? Yeah.
Well, yeah, and that was what kind of struck me. And Tim, you refer to there, Tim Beams. I
Yeah.
was chatting to him yesterday, as you know. We're all kind of in the same field, trying to do our thing and sort of joining it up in this kind of way. But before we kind of get into the pain stuff, um, I mean, tell me. I don't know. I don't know how you got into pain, and I'm assuming before you got into pain, you got into physio, and they're not the same. And maybe there was
No.
stuff before that. So how did it all begin for you?
Um. Well, yeah. I always had an interest in dealing with people in one way or the other. And then I got into physio school back when it was an education without a degree, so there was no bachelor's degree, there was nothing. I did that. I was very happy. I started to train as a manual-therapist. Did that. Was very happy. I could fix people. I loved that bit. At some point, I realized that maybe I couldn't fix them, and a lovely person I know gave me a book that was just recently came to Denmark at that point. I think this is 2005 or something. Book called Explain Pain.
Right.
And as you know, that was the starting point for many of us. So I started to go about listening to Dave and eventually Loz as well. And I went to this course in Oxford. You might have been as well, where Mick Thacker and Lorimer and Dave gave a shared course, which I think would have been maybe in 2006, 7-ish, and I was hooked. It sounded like that's the way I want to go. So I spent a lot of time trying to understand it. I started teaching for the Norway group, so doing the Explain Pain courses. That's where I met Tim. And apparently he knew a lot of the stuff that I was wondering. So is this really true, or am I just saying it? So I would be saying this when I gave courses because I heard it. You're trained, you read the book, so you're giving sort of the same explanation on to participants. But Tim somehow knew stuff that was outside of that, and it turns out that he was doing the MSc program at King's, where Mick was leading it, which you've been doing as well. So the course there was really the turning point for me, wasn't it? Where I stopped looking into being a physio as per se, the old type physio as fixing things, and then looking more and more into the philosophy and the science behind pain, and it just took me by storm. I was so thrilled by it that when I stopped the master's program, I went back to the clinic. I've been a clinician since 1999. Went back to the clinic, but more and more I wanted to do some academic work. And in 2015, I got a fully funded PhD doing basic science, so neuroscience in relations to pain. So we were testing out healthy human beings to see if we could initiate pain and then modulate it, studying the descending modulatory system, which was there were tough years. It's really tough coming as a clinician without any sort of really strong scientific background, never been to the labs, and then starting to do all of that work. But it was also a very, very steep learning curve. I'm very happy for the people I met there, and I still work. I'm now an associate professor at Aalborg University, where I did the PhD as well. But instead of doing it with the Center for Neuroplasticity and Pain, where I did my PhD, I'm now affiliated with the implementation part. So it's called Musculoskeletal Health and Implementation Group. We're looking into what we call the pain path. So how do people with pain get more swift and better through the system? So how can we initiate early assessments? How can we avoid delayed or unnecessary treatments? So this whole pathway, how can we do that? And we come from that from many different perspectives. So people with communication backgrounds, people with psychology backgrounds, and we've actually just this month we've invited a visiting professor down, who I'm sure you know, Lance McCracken. So he'll be with us for the next 3 or 4 months, trying to support us in developing new methods to study on an individual basis, how do people change. So it's called single case experimental designs. It's sort of a single case. So you study one person, and you, rather than having many people where you get a few data points, you have a few people, but you get many data points. And then we sort of want to develop that field and see where that can take us, and maybe that can show us that some treatments are actually effective. So thinking of it, so I'm doing that part-time. Let me just say that first. I'm doing that part-time, and then I still see patients, and I do a lot of teaching and writing and all of that in the rest of my time. But one of the things that the RCT, the randomized controlled trial, really does is it looks at a group and it gives you a mean score. So do the majority of the people in the group seem to change based on statistics, which has a lot of validity, but it doesn't show who benefits from the treatment. So the single case experimental design studies are trying to look at that from a different angle. So looking at one person. It's been around in pain for many, many years. So there's an old study by Johan Flane and sorry, I can't remember all the authors, but they looked at graded exposure, where people were exposed to the things they were afraid of and combined that or compared that to just active engagement in doing physical activities. And it shows that when you're doing the things that you want to do, you see a change in the score. So they could look at pain scores, or they could look at activity scores, or they could look at fear avoidance behavior scores. And then you see when they are exposed to the things they're afraid of, the scores change. When they just do activity, they don't change. And you can see that on an individual basis. So there's a lot of things gone through that method since, and it's still not a completely developed method. There will be a review out in the European Journal of Pain, hopefully sometime this year, from Lance McCracken, who's one of the forefront leaders in the field. So we're very much looking into that. That's a long talk, and then on the university side, maybe I should say that as well. I teach on the MSc musculoskeletal pain program we have for physios at Aalborg University.
Yeah. Wow. I mean, that's a hell of a journey. A very cool one, a very necessary one, because pain being such a huge, particularly chronic pain being a huge problem across the globe. Did you ever imagine that you'd be in this position doing what you're doing now?
Never. I mean, I think maybe I'm getting tired of hearing that, because I think that's everyone's story. But when I was I was struggling. The only thing I sort of really excelled at was language. I could speak languages. That's the only thing I could. So I never imagined I'd be doing anything scientific, anything that needs, structure, any of that. But I guess interest drives you to do many things, and I just got the academic bug, and then once you want to learn it, it's much more, there's enthusiasm, you're motivated, all of that. So I never imagined I could do any of that, but I'm very happy with what I'm doing now.
Yeah. Well, yeah, that's clear. You have a passion and a real purpose. But it's interesting, isn't it? Because as you said, other people have this experience in, because school and education systems are often very confining. You're told what you've got to learn. You're growing up, or there's all that stuff going on. And if we chatted to some of your teachers and and they say, oh well, Morten one day is going to end up a top academic, they're going to be like, what? And I think my teacher would be laughing at what I'm doing as well, and because it's just totally different. But as you said, when you find something, these switches, and you must have found something then that turned you towards physio in the first instance. So that sounds like that was the first turning point. What happened there?
I had a bit of backache. I remember the specifics actually. It's one of the things that I remember very clearly. And I had backache. I was in the service, so military service at the point, and I had backaches. I went up to the physio, and whilst I was getting my back rubbed, whatever he did, I was just chatting, loosely to him, and I said I always was a bit fascinated about the body, and I was thinking about maybe, I wanted to study history when I came out. I wanted to go to university and study history, maybe philosophy. Wasn't clear of that, and then I said I want to do some of these like weekend courses where you could do like whatever reflex therapy or whatever you can do on a weekend course, right? And he said, why not go that direction? Why not be a physio? I was like, physio? I have never even thought of that. So I spent a bit of time thinking, finding out what it was, and it turns out that I had the merit, so I could get in. At that point, you didn't have to have grades; you were admitted by your curriculum. So I submitted my my application, and I was admitted. Very luckily, I would say. That was quite interesting. Never thought I would go that way though. All day I've always been fascinated by body and health, and I've been doing martial arts for a few decades. So that was sort of my lead into the body, wasn't it? And
How long were you in the military for?
I was there for I was actually there for quite a few years. I was in intelligence services, so I was there for a few years.
Okay, and that was, so you went to school, did school, finished school at 18,
Yeah, roughly.
and then straight into the military, or?
No, then I went. So I did what we would call gymnasium, but only I did the business gymnasium. I thought I was going that direction. My family was working in tradecraft and all of that, so I figured that would be my trajectory as well. And then after that, I went to the military. I was drafted, so I had to go. But there was an opportunity. If you applied for it, you could go straight into being trained as an officer. So I went in to do that, and then you do that for a few years, and then you're put in a position, and I was working in the intelligence services there for a few years afterwards.
Yeah, which I guess you can't talk about.
Well, yeah, well, I can't, but it's not interesting. I wasn't doing any like 007 007 work or anything. It was really mine. I was just a pissant on the floor. But
I'm kind of into spies at the moment. I'm having a bit of a spy time, watching a few spy things. So maybe we'll chat about that some
have you
time.
followed what happened? So in Denmark, we had the military spy chief. He was arrested for sharing information, and he's accused of I think anything you can come to, but even being a traitor to the country.
Wow.
And it's either a huge scandal or there's something I don't understand. So it's really interesting. There's a lot going on. So spies are big here in Denmark at the moment as well.
Yeah, it's trending in Denmark. But I think the problem is when you watch these spy things. I've been watching Slow Horses with Gary Oldman. I don't know if on Apple TV. You watch this stuff and then you get very suspicious about your own intelligence services, and what they get up to, because you're kind of imagining that although these are sort of stories, they're kind of based on something.
Yeah.
So.
But I always think who would benefit from looking over my shoulder? I mean, even if someone was in my phone at the moment and they would see us chatting, well, they can just go online and download it afterwards. So anyway, so
Yeah.
I don't know, but definitely we could be monitored much more than we are aware on a daily basis. I'm sure of that.
Yeah, we're definitely being monitored. But I'm just wondering how, that time, in the middle of the officer training, and then your time in intelligence, what kind? I mean, you would have been taught some interesting things there. You would have developed some interesting skills around people and
Nah,
reading people and situations. Do you think?
no. I guess that's only if you were truly in in the service where you're doing it undercover. So it's called intelligence. Basically what it is it's just collecting information that is being passed through the system, and obviously you have a bit of clearance, but it's nothing. I mean, the only sort of actiony thing I ever was part of was I was listening to the chatter and following up. I was collecting the chatter that happened during the Iraqi war. So you're sitting in the war room and collecting information, but I mean, it sounds interesting, but if you did a movie about it, it would absolutely be a fiasco. It's so boring. So don't think that just because it's intelligence, it's exciting. No, unfortunately. But I would say, having been teaching for many years, learns you a lot about people. So the
Right.
teaching, being engaged with people, explaining how to do, bodily exercises. So for martial arts, for instance, which I've been doing for many years, as I said, that I was teaching that for many, many years, and just learning how to communicate with people, make them reflect on how their body works. That's been an interesting journey. I think I learned much more from that than anything I would ever learn in the military.
Yeah, and perhaps even more than physio training, I'm wondering. Within because I don't know what your kind of training was like, but that kind of real detailed understanding of movement, relating to the embodied mind, stuff that we're very familiar with now, but maybe back then we hadn't even heard of. But I would imagine that martial arts would have been much closer to that way of thinking back then.
Yeah, absolutely. The thing I did was strongly associated with Zen Buddhism, which is sort of a very clear trajectory of what we are doing now as well. We're looking, supporting people in finding themselves. It was something like mindfulness is straight out of the Zen Buddhistic book, isn't it? But yeah, I think you're right that we didn't focus as much on that as we do now. But I remember having done that, so that was my approach to feeling and being, in your body when you move, and understanding that other people have other bodies and they're not the same. And then coming into physio school and learning about anatomy, I remember getting a system where you could describe precisely what is going on. That was a revolution. So really combining that sense of self with, you could say, basic science. That was quite a journey for me. I love that bit, being able to explain what you really are looking at in a more ordered fashion, you could say, or structured fashion.
Yeah. Yeah, I mean, you bringing that background into, particularly when you were training, and then maybe the early years of when you were working. And I mean, was sort of meditation part of the practice back, your own personal practice back then?
Oh yeah,
Okay. So
yeah.
so you had that background which you were bringing into the physio. I'm just interested if you ever met any kind of resistance, or were people quite open to that way of thinking back then? I mean, it wasn't that long ago, but it's still 20 odd years, isn't it?
Well,
20 years.
yeah. Good.
Yeah.
Well, it's more than 25 since I started, wasn't it? So
Yeah.
it wasn't something that it wasn't considered real therapy. It's something you could do, and it will still be on a spectrum of body and mind. So you would be doing that for your mind, but the real thing that was wrong with you was in your body. So you had to learn manual therapy. Um, I mean, you would have been to school around the same time. I mean, exercise wasn't even a thing at that point. You learned exercises, but doing strengthening and conditioning training was not part of the program in any way. We'd never thought of it as therapy. It wasn't until whatever 2010 or something where exercise as medicine started, and we really realized that exercise was part of being healthy. Back then it was about, it's more about bodybuilding if you did strengthening training, which
Yeah.
obviously I haven't been doing, but I know people were doing it.
Yeah, no, I mean you're absolutely right, and it was the same here. So before I did physio, I did a degree in sport around that, working with the active population, which was set up by a physio who realised, right, there's a massive gap here. We've got all these physios giving advice on exercise, but they got no background in it unless they've done their own stuff and additional stuff, which obviously some had. But the majority didn't have a clue about exercise prescription. They were just kind of making it up. 10 by 3,
Yeah.
all that.
Yeah,
Where's that come from?
exactly.
So yeah, that was been a really important change, because there's all these assumptions made that physios know about exercise.
Yeah, I agree. It's I mean, that's been one of the most important journeys we've been on. alongside, I would say, of course, with the pain journey, coming to new understandings of what pain is, and maybe particularly what we can do about it. I think you and I would be on the same page there, but very, very sort of bluntly speaking, you could say that I thought I could change people's pain, whereas I now realize that, or I believe that I can't. I mean, they can change their pain and I can be part of that process, but really I don't know how to change it. In order to really make change to someone, you would have to be either a surgeon or use pharmacological treatment, and I do neither. So the chances that I leave any changes in the way I can do it is obviously by making them behave, change, maybe even think differently afterwards, if you conceive that as a biological change. There was just a paper out this morning from Aalborg University, actually. Rocco, one of our colleagues up there, and Lars Aron Nielsen, they looked at microRNA changes after a brief stimulus, 5 minutes of painful stimulus, and they can detect changes on a microRNA level. So obviously you can change things, but what we are changing in our therapy is probably very blunt and very crude. So you're doing something, just like exercise, you're doing something to an organism that is so complex that, I mean, you cannot even compare it to playing pool, where you have one white ball and you hit it into a bulk of other balls, and you are sort of supposed to predict where every ball goes. That's just not going to happen, is it? And then the body is going to be massively more complex than that. So we need to understand, and I think that's what neuroscience helps us do, is to understand the boundaries, the limitations, or the principles of how that works. Like you would have gravity in natural forces or natural sciences. I think there are similar to the human, based on what we know about neuroscience. For instance, the descending modulatory system, how your nervous system can change signals in your nervous system that do to some degree relate to pain. I understand the concept is that you can change it from 0 to 100%, but in reality you don't. So in reality, maybe you work, let's say 15-20%. And I guess that's also why we see similar effect sizes from similar treatments. So you do manual therapy, you can combine it all, you can look at it compared to each other, and you see small effect sizes, small to moderate effect sizes, equivalent of maybe between 2 and 4 on a 0 to 10 scale on short term, right? Or you can do exercises and you see the same, or you can do hypnotherapy, or you can do pain neurobiology education, and you see similar changes. I think that reflects, at least that's how I perceive it, that reflects the restrictions that we are part of, being in an organized manner. So we have this incredibly complex organism, which we call a body, but in order for it not to disintegrate and just become nothing, or go in too many different directions, you have to sort of keep it in play and keep things in control. And I think that's what neuroscience, or basic science, is helping us understand.
Yeah, those kind of parameters that we can work to. As you said, change from any given practice, exercise, intervention is just a step. It's never the end result. And it seems that people want an end result. I want to be better. And change is a process, again, not a point in time. And it's interesting, that first bit that you were talking about, can we change people? And when you were saying that, inside I was going, oh yeah, great, because not many people say this, and it's not popular, I don't think, because it's the reality. We don't change. I mean, I actually argue that we don't really even treat pain. I mean, we can get into that if you want, but it's more about creating the conditions. So this comes a bit more from the Zen or Buddhist philosophy, that with someone, as you were saying, we can create the conditions if they're in pain, they're already in pain. There's nothing you can do about that. It's already happening. What you can do is create the conditions by doing whatever it is. And if they keep doing those things, then they're going to be on a path, those parameters that you were talking about there, healthy parameters, so skills of being well, exercise, all that stuff, looking after yourself, self-care. And if you're staying within those parameters for long enough, consistently, there's a very good chance that you're going to feel better than if you don't do that.
Yeah.
Does that kind of fit with what you were saying?
That resonates very well. I would even say there's, you know, the other side of that is, let's look at surgery, for instance. I'm not in any way against surgery, but I do think there are things you shouldn't surgerize on. So if we use the same approach, saying that the body is a controlled organism and that's the way it works, then doing surgery to that organism is putting it out of control. Sometimes that's exactly what you need. Maybe it was out of control and you're supporting it to finding its way back. I think that's fair to say. Let's say a fracture, an open fracture of your shin. You definitely want some sort of surgery to help you there. It's unlikely to heal by itself. I don't think the body has the capacity to do that with the shin outside, at least not put it back in place. But when you give surgery to people who are maybe already wobbly, or the borders, or that what you were talking about, that balance they're finding, if that's already out of balance or out of homeostasis or whatever we call it, and then you add surgery to that, I don't think you're doing people a favor. You could argue that, you know, again, taking that perspective, I think that makes sense why you have to also always consider the risk and benefit before you do anything. So a good example of this would be the sort of now lesser commonly used approach, but still quite common approach, where you say, if you're in pain and I have something that could help, you should try it. Essentially, that means that if you have back pain and nothing has helped, then you should have opioids or you should have surgery, because it could help. Whereas I would argue that maybe at some point we should stop trying to fix people and support them finding a way with the life they have. You could argue that's very Zen Buddhistic, so life is pain and all of that. But finding acceptance, you could use that word, that's a newer word, but it basically means the same. So you could find acceptance of where you are and try to make the best of that. Obviously, that's not something that you just do. I mean, monks would train themselves for years and years to learn that. And then we say to patients, go ahead and learn yourself to live with that pain, because I have no clue how to do it. We would paraphrase it. We would say, you need to learn to live with this, but it's idiotic, I think. That's giving someone a task where they're definitely not ready. So you need that support. And I think that's the role we could play, is helping them to find the boundaries you were talking about, and also advise and help to discuss the benefits and the risks of going outside of that, you know, your body's own, you know, ability to find its way back, whatever you call it.
Yeah,
I know it sounds
so
quite fluffy, and I think it is fluffy at the point, but I think there are things that could support this idea.
Yeah, I mean, absolutely. It's kind of this shift, isn't it, from the fixer, which essentially we've been trained in. I mean, I think it's slowly, the idea of that is slowly changing. You know, people like Roger Carey, you know, pioneering new ways of thinking about the undergrad training and such like. But yeah, this shift away from being the fixer to being the guide, to being the encourager, the motivator. I tend to use the word coach to umbrella all of those things. Where you're coming alongside someone and helping them on that journey. Do you think that journey is about making things better, or just managing? What's your kind of
So
feel on that?
from whose point of view? From
Well,
our
from
point
the
of view, or
person,
from
from
the
the no,
patient?
from the person with the lived experience of pain. You know, are we trying to help them have a better life?
Again, from the person's perspective, this is one of the discussions I had with Lance this week. Actually, is it realistic that we, through education, can support this patient in being better at utilizing health care. So can we train health literacy, for instance? Can we support them in asking the right questions so that they are asking us something we can actually help them with? Should I do surgery, as opposed to, do you think surgery could help? So could surgery help? The answer there would be yes, it could. In almost any circumstance, surgery could help. It depends on, the risk you're ready to take. But should I do it is a completely different question. We can spend a lot of time really give them a good answer to, or maybe we need to go into therapy straight away. I'm not sure where we should. Again, I'm taking my own point of view here. So from the person's perspective, I think it's important that they know that we can't do everything, so that they start to reflect on, what do I need? And obviously some people will be very good at saying this, and I would argue get more and better help. And some people will ask for things that are more tricky, such as if you had pain for 5 years and you say, I want the pain to go away. That's a really difficult task, and chances are, if people say, fine, go on the couch, they're taking a chance. They're not looking at statistics first. And maybe it could help, but chances are that it won't. And then should you then, as a person, be understanding that you're also taking a chance, which is disappointment and lack of confidence in treatment, believes that your future can be better. So are you willing to risk that by taking up another bout of therapy that may not help you in any way and give you negative experience and expectations? So yeah, I keep coming back to my own perspective. I'm not sure how to respond from another person's perspective. Sorry.
No, well, maybe we can't. Maybe we can't. I mean, I think that we can hear what people say, and obviously they come and they want things to be better. And some people's better will be, I want to be pain free. I want this to have gone away, and we have to have that conversation to kind of get the expectations and reality aligned in that moment. I mean, no one knows the future. That's So what was it going to be like someone asked me the other day, what's it going to be like in 5, 10, 20 years? Oh, I said, I have no idea. I mean, no one knows, but some people do tell others, oh, well, in 5 years you're going to be this, in 10 years you're going to be that, and obviously they're using it based on their own experiences and maybe some data or whatever. But ultimately, you don't know. So I guess it's trying to keep people open to possibility and say, well, look, these are feasible things you can do to live your life in the best way right now, because this is the only moment. And if you do that and you're open to possibility, I think that things can improve for you in ways.
Yeah, and some people do actually benefit from long-lasting pain. I mean, there's a range of studies. I mean, the most recent and probably the most popular study at the moment would be Joni Usher's and Tor Varga's study on pain reprocessing therapy, where a group of people with 6 months of back pain, more than 6 out of 10, 4 days a week. So a sort of quite difficult group of people to manage on a statistical basis. And they managed to cure, so reduce the pain to zero in 1/3 or more of the people on I think it's an 8-week program, a 6-week program, where they insist that the reason for pain is changes in your brain, and the therapy changes your brain. So neither can be documented. So they are postulates or theories, if you like.
Yeah.
But still, the therapy helps. So the problem is, of course, you don't know who would benefit from that. And I would argue that maybe you can't necessarily say that it was the therapy. There could be a lot of other things going on, such as the communication and enthusiasm of the therapists, etc. So there's a range of things, and I'd like to see it replicated as well. But you've seen the same in cardiac surgery, where you had angina pectoris surgery, and it turns out that placebos are just as effective, but still they remove 100% of symptoms in some people.
Yeah. Yeah,
We need to bear that in mind when we're being a bit negative about the possibilities of managing a person managing the pain. Obviously, there are people who benefit from being told what's wrong and then doing what they're being told. I'm just not sure who it is.
Yeah, I mean, that's the thing, isn't it? There seems to be, there is a way forward for some, for people, but it's finding that they've got to find that there's no one way. And it's interesting you brought up the reprocessing, because I mean, undoubtedly those results are very good. I mean, it's in about 50 people, isn't it? So it's a small number of people with back pain, I believe. Is that right?
No, I think it's at least 20 in each group. I think it might even be more. But anyways, it's I I don't see the obvious statistical mistakes. That's my way of saying I can't see anything wrong in that study. I think it's a brilliant study. I've had the opportunity to discuss it both with Yoni and Tor, and I don't get it. I just don't understand why they have so big effect sizes. But I mean, results matter, and their results speak. I guess the thing that is really interesting is that the placebo group and the treatment as usual group get a similar effect. That is quite unusual. Normally, what you would see is that treatment as usual has the worst or the least effect, and then placebo has a similar effect or almost similar effect as the active group. But in this case, the active group are doing significantly better at anything. I mean, at all time points, and there's I think it's a 6-month follow-up, and people are pain free, which is spectacular. I mean, imagine being one of those people who go to therapy, who had pain for 6 months or more, and you go to therapy and you meet this enthusiastic clinician, and your pain goes away. I mean, you would be blown away, and you'd be telling all your mates about it, wouldn't you?
That's very powerful. The stories are very powerful, and then that breeds expectation, which we know is enormous in all of our experiences and perceptions. So, well, I mean, what do you think of the term then? Pain reprocessing. Essentially, what it's saying is that you reprocess pain.
Yeah. Well, I don't want to. Well, actually, I am probably completely against that. I mean, we have a similar discussion here in Denmark with concussions, for instance. Are they brain injuries or aren't they? And I would argue they're not brain injuries, because brain injuries is actually, that is the thing you don't have. A structural damage to your brain is the one thing you don't have if you have a concussion. You might have similar symptoms, but you do not have that. Otherwise, it would be a traumatic brain injury. And then this term mild traumatic brain injury has been introduced as, as to say you have the symptoms, you just don't have the structural damage. Well, in sports medicine, you would have anything is a sports injury, right? But when you look at the majority of the people, they have no injuries, as in tissue injuries, but they're still conceived as tissue injuries. And we thought that wasn't a bad thing, because they're just injured. They can't do their sports. That's how they define it. But really, what we are telling them is that they're injured, and it turns out that that's what they hear. So they do say that my pain is my injury, but my injury is causing the pain. So you need to care for my injury. And if I have more pain, I can't do my sport. And there's some evidence pointing to the fact that maybe therapists are thinking that as well. So they would have people who could actually maybe be doing their sports stay off the field because they're afraid of the pain, which is, how would you know? I mean, you're changing the pain. Does it have anything to do with the nervous system? Obviously. Are you doing anything specific to the nervous system? Absolutely not. I would argue you could do exactly the same with a different placebo. So if their placebo in that study was injection of saline, but if you had mindfulness as placebo, I would imagine the differences would have been less. So if you do something that you are engaged in and you believe in, and you have an enthusiastic instructor or teacher, chances are that the differences wouldn't be as big. So I don't think that study suggests that pain reprocessing therapy works. I think it suggests that being with an enthusiastic therapist works. And honestly, I think that study is a really good reminder of what people like you and I and others who may not have our fingers so much in the daily treatment of acute pain or early onset pain should remember, namely that our colleagues out in the clinics and in the hospitals and everywhere else, they're doing brilliant jobs in the majority of people. And the people that we see are the people that didn't go on that trajectory. So I think there's miraculous curing happening every day in the clinics. I truly believe that. But there are people who are, resilient maybe to that.
There's a lot of brilliant work, and in the sports field as well. So when I go and talk to the groups and on chronic pain in sports, so the management of acute injuries and things and dealing with that, it's brilliant, absolutely top drawer. But actually, the skill set and knowledge that you apply there is just not appropriate for people who are still struggling. But how can we look? How can the ever question? How can we identify people earlier? Well, maybe in some cases, many cases, maybe you can't. Maybe it's very difficult to say, because how many people do we see who have had a problem for 6 months, 6 years, 16 years, whatever? They, previous to things happening, their life looked not vastly different from the majority in the middle of the bell curve. Yes, everyone has traumas, some with big T's and little t's. Some come resilient from that, some don't. Some have genetic stuff and it just pops up because of certain, it's just immensely complex. And I think that, working with people with persistent pain, chronic pain is even more complex, because you're getting to the heart of all of this stuff, which makes it very beautiful and fascinating, but it is a huge challenge.
I just keep going. I love what you're saying.
I
really agree.
So thinking behind those.
So I guess strictly speaking, they're editorials. So they're peer-reviewed editorials. My colleague and the professor of my department, Michael Ratliff, he encouraged me to write this series of editorials for the JOSPT, or to submit it as a suggestion to the JOSPT, and we had a very fruitful debate with Claire Aiden, the editor-in-chief of the JOSPT, and we decided on trying to come up with does the word pixie book, do you have that in English? So we have in Danish, we have pixie books, where when you start to read, when I started to read when I was a young kid, then you would have like these tiny books, and they would tell a story in 4 pages. So it's like that, very short form, but still you get the whole story. You of course there are things you don't get. You don't get the nuances. You don't get all of that outside of the mainstream, but you do get the storyline, even if it's on 4 pages. And that's the idea. So we have 1,500 words in an editorial, and we need to tell the story of something relevant. So the first ones were a bit harder to come through, and the reviewers were a bit harsh to say, well, why is it important to tell clinicians about neurons and receptors and the differences in types of receptors and second messenger systems? Why is that relevant? And then once we started getting into the sensitization, so first the peripheral sensitization, and then now the central sensitization, which is the one that recently came out, and then we have a second one coming out in I reckon next month on central sensitization as well, but where we discuss the different types of central sensitization. Right. So the story now is that we have these lines of editorials that gives clinicians an insight to the language that is used in neuroscience. And neuroscience, in my opinion, is the science that is the most at the forefront, I would say, of studying pain. Obviously, we have no clue how neuroscience and pain relate. We do have clues, but we don't know exactly how does perception or consciousness relate to neuroscience, but it is the most widespread, most used basic research approach to studying the phenomenon of pain. And in doing so, of course, what we are really studying is nociception, especially if we do it in animals other than humans. But in humans, you are studying pain, but under the assumption that nociception leads to pain. Yeah. And that's given us a lot of insights. Obviously, it is unlikely to ever give us the full story, because I believe there's more to pain than nociception. But having said that, nociception is an ideal trigger for pain. So I usually say that imagine you were to do a study with 100 people and you needed to get each of them to feel pain, but you couldn't touch them in any way. So you couldn't do anything sensory. How would you make them feel pain? And you have to do the same thing to all 100 people. So people would say sleep deprivation, but again, maybe you're not feeling pain, spontaneous pain from sleep deprivation. You would be more responsive nociception is an ideal trigger for the sensation of pain or the experience of pain. But where we are now and where we should go is still a long way. I mean, there's a long way to go, but what we are trying to do with the series essentially is to build a bridge between where science is now and where clinicians are now. So it's essentially a way to teach. So again, at the university, when we do our MSc program for physios, the editorial forms a basis of what we need to teach them about neuroscience in order for them to understand, for instance, low back pain. And you say, how could you? Because it doesn't tell you what low back pain is. And I think that's the wrong approach. I think when you know neuroscience, for instance, you know what it isn't. So you can identify sensitization when you see it, but you can also say this is not something that easily is explained by some of the principles that we usually see in neuroscience. So the pain you have, the trueness of the pain or the experience of pain is different, and it doesn't lend itself to be reduced to a single or a few mechanisms. And that makes me much more, so as a clinician, I would be much more, I need to spend more time understanding you. What triggers it? What happens? What does it? Because the easier it is, imagine someone comes in with a broken leg again, a fracture. It's so easy to understand. You don't even have to consider the difference between nociception and pain, because you know exactly what you need to do. But the further away the person in front of you gets from that picture, the more you need to sit down and listen to their story. So I see it almost as a continuum of understanding. So the basic understanding of acute pain, for instance, is really well explained with what we know about neuroscience. But the more we get into complex pain, the more you need to have the tools and skills to listen to and facilitate your person in front of you, the patient, to give you information. And still, I would use my understanding of the body, how it works, to rule out things such as serious pathologies and commonalities, early warnings to signals of rheumatological diseases or whatever. So I think that's how we should use it. So more basic science helps us become better clinicians, I would argue.
Yeah. I mean, I totally agree. Often the start point's taken from an injury moment, or sometimes just a moment where the person goes, right, I need help now. I need to go and see someone. So they may have had, times before where they felt pain, but for whatever reason, at that moment, they're like, no, I need some help. How much emphasis do you put on, how their systems have developed and evolved and what they've learned prior to that, that at that point that they do that sends them on a particular trajectory?
Yeah, I try not to predict what goes on inside the body. Hence, I can't see it. I can't measure it. So it's not something I could change either. That's the problem, isn't it? If I thought, again, talking about pain reprocessing, sorry to take a back turn here, but the reason I don't like the idea of pain reprocessing is because you can't really see or measure it in any way. So you're just predicting or playing around with it, saying, I think that we are changing the way your brain works. What you are really looking at is how the pain changes, not how the brain works. So why not just call it that? And I would say the same. I spend a lot of time listening to the story of my patients, because I think there are many things in, again, coming back to this idea that we are all living as controlled homeostatic organisms. So if your history explains to me that you had knee pain and then it went away, and then you had shoulder pain and went away, and then you had headaches and it went away, and then your knee pain and your shoulder pain came at the same, but it always comes and goes, then what should suggest that the current pain you're in should be any different? That's the question I would ask. And I would ask that literally, and I would also question them about, so have you ever experienced, is it similar? Could I, with my knowledge, clear my conscience for serious pathologies? Could I, avoid being suspicious of that? All of that, and then, I spend so my answer is, I spend a lot of time understanding what they have experienced before, but I don't try to predict what goes on in their system.
Right. Okay. So it's much more of the narrative you're interested in, which of course we access through asking and listening, which we. And do you feel that then puts a context? So you've talked about, the story of their pain, that maybe the story of their life, how their health has been, not just this sort of list of things that have happened, but this is their life story to date. You use that, and then you can put some perspective to what they're experiencing now. Is that right?
Yeah, absolutely. That's so true. And especially I like you point out that the context is, because it doesn't have to be the pain that changes, it could be the context. And in that context, they experience life differently. So let's say the pain is the same. If you ask, how's your pain? It's 4 out of 10. It's always 4 out of 10. But sometimes I can be quite, happy about my life. And sometimes I can be devastated, but the pain is still 4 out of 10.
Yeah. Yeah. People say that, don't they? They say, oh, my pain is the same. And I always find that really interesting, because, as we've already intimated, we somewhat influenced by Buddhist thought and well, certainly impermanence. Can anything ever be the same?
Yeah, that's a good question. And obviously it can't, but then it always will. So depending on, I guess, the level you're looking at.
Yeah.
Um,
Yeah. And then the other thing that
I guess that the answer here would be trying to answer it fully. I would say, in order to stay the same, you need to change, because you as an organism cannot stay the same in a continuously changing environment and feel the same way. So if you did not change at all, everything else changes and you would feel odd and awkward. So in order for you to feel normal, you need to change along with the changes around you. I guess that's how I see it.
Yeah. Do you think that happens anyway? Which I'm sort of tying in again. We're sort of going back to this idea of people trying to explain the change in experience by the change in brain, and I'm always thinking, well, the brain's changing all the time anyway. So
Exactly.
how do you know it's got anything to do with what you're
Yeah.
suggesting? There's constant flux and change. You cannot help but that happen. And I guess neuroscience is the study of that change.
It is. And then so in basic science, what you always want to do is you want to have a control condition, right? So you want to know what you're measuring, and so as a fixed point, if you like, and then you measure something else and see if one changes, does the other change as well, and you would maybe communicate that through a p-value or whatever. And I mean, we can do a lot of, imagine brain studies. So you can do brain imaging, fantastic studies, amazing amounts of data, great for AI studies or machine learning. Thing is, if you want to study perception, then what are you really looking at when you look at the brain? And obviously what you can do is you can you can manipulate people. So you can put them in a scanner, you can manipulate. So before pain, after pain, that would be an easy manipulation. The same person in the scanner before and after pain. And then you could postulate that the changes in the brain related to the pain. That's been done, so much. But if you do the same stress or sleep deprivation or a lot of other things that sort of changes the way you are in the world, you would see similar changes in the brain. So maybe we need to have better theories of what does brain changes really explain to us. So I guess it's the opposite of what we've been used to in terms of research. We always said there's not enough information. But when it comes to brain studies, we have too much information and too little understanding of how to put them into context. A lot of people would use this default mode network idea that some of your brain is working constantly, and then you have changes that are related to what you're doing. Maybe that's true, but we still need that breakthrough theory that can explain and then hopefully predict what goes on. So if this happened, we will see this. And there are some brilliant studies. There are many fantastic researchers out there doing great jobs, but the breakthrough is still, as far as I understand, to be heard of.
Yeah, no, absolutely. And I think that the waters get really, and so my assumption there is, your series of articles is going to help clinicians navigate this world so that we all know what we're talking about, rather than this sort of muddying of experience and changes and what I saw these changes. Well, what kind of changes? A clinician, I saw these changes. Your brain must have changed. Well, it's changed anyway. What do you actually mean? What are you really describing here? Because then if we're all talking a similar language and that gets better, then clearly it's going to be helpful and take us down the right path. So I sort of see the articles playing a really important role in that.
Thank you. I would love to see that as well. I mean, I think that's a really important point, and definitely one of the main drivers behind the article series is trying to clarify what it is and particularly what it isn't. So we try to reflect it back on the clinic. So I mean, there's a lot of hypalgesia, that normally painful stimuli are more painful under certain conditions, for instance, during an inflammatory process or sensitization. I would argue that's the same as we see in the clinic when you do pain provocation tests. So let's imagine you have someone comes in and they have a single painful test. So if you do leg squeeze test for someone with groin pain and they say that's painful right there, then I think chances are that there is something in that area. And I think the theories that postulates it's tissue-based and the theories that would say it's pain-based or neuroreceptive are probably equally well. Just lead you to one thing, is that maybe don't provoke it, give it a bit of time, let's end up the same place. There was just this week as well, there was a new article out where they tested exactly the groin area and looked at different tests. And if people had pain, so these were football players in first division, so early amateurs or maybe late amateurs or maybe early stage professionals. And if they had pain for more than 6 months, the chances are that when they did the tests, they would have at least 5 or 6 positive tests. So different things would make their pain respond. And the articles, so it's Matthias Nielsen is the first author, and Christian Thorborg, I think, is the last author. And they say that one way to interpret this is that maybe if you'd had pain for more than 6 months, 6 weeks, not 6 months, 6 weeks, maybe there are more anatomical areas involved and maybe you have more diagnoses. The other chance is that maybe it's about your pain system or the nociceptive system. Maybe it's about pain. Maybe pain is actually a better way of explaining those more complex widespread pain, whereas when it comes to a single pain, it isn't. So that's what the series hopefully should give us a narrative of, to communicate and to use those narratives that are used in pain science more into sports medicine, more into manual therapy, more into that, sort of understand if we're seeing the same thing and using the same mechanistic terminologies.
Yeah, that's really interesting. Really interesting, because as you spoke about earlier, you know, the pain and injury are still used interchangeably by people, including, you know, professionals, when they're completely different things. And often, you know, when talking to the guys in the sports med field about chronic pain, you know, still refer to, you know, Pat Wall's 79 paper and lecture, which is, you know, a long time ago. And increasingly, there are people in the room who were very small when that paper came out. The age thing, which always tickles me a little. But yes, but it's so important, isn't it? You say people come in, oh, I've injured myself again. I've redone my hamstring or calf. You sure? Yeah, it hurts. Therefore, it's sort of cause and effect. Okay, and I guess
I
that's the
agree with that.
statement.
We had an editorial in BJSM a while back on that, exactly on that. And we suggest that we should try and utilize two new taxonomies instead. So have sports-related pain and sports-related injury, under the assumption that they are A, different, and B, both should be addressed. So in the person with hamstrings, you could still train the hamstrings, but if there's no injury, you don't need to take care of healing times. Maybe you could go straight back into playing, or maybe you need to stop, you know, doing specific things, but you can do other things. But instead of being guided by healing trajectories, you could be guided maybe by what we know about pain and sensitization, that sort. So sports-related pain is not the same as sports-related injury, although the athlete could feel it exactly the same way. They would say, my hamstring is gone again. But the diagnosis, so to speak, would be different.
Yeah, which would ultimately lead to you doing the right things, better things, more useful things. I mean, on a basic level, at the moment, as things are for you, when you're talking to perhaps a group of people, and you're telling them what is pain, what is pain for you at the moment? Where are you on that kind of simple question?
Yeah, I'm very easygoing. I think I'm very pragmatic. I would say whatever the patient says. So pain is, you know, by definition, I don't disagree with the IASP definition. I think it's thorough. It's a good job. I think the most important bit is that if it feels like injury, it probably is pain. That's part of the definition. So pain is something you experience, and it usually feels like injury. So from a person perspective, a lived experience of pain, you wouldn't be able to feel the difference between being injured and having pain. So whatever the person tells me, jump to the same conclusions as the patient has.
Yeah, that's interesting, because you're right. You can't feel an injury, can you?
No, why would you? That's what pain is there for.
Yeah, exactly. So you feel the pain, but you can't feel an injury. Much like you can't. I mean, this is an interesting one when you say to people that you don't actually feel your body. You have all these sensations or perceptions. That's something we haven't spoken about, the difference between perception and sensation. That gets people excited.
I leave that to much smarter people than me.
Yeah, I think we won't go there today. But those things. So I don't, you know, there's my hand. I don't actually feel a hand. I feel some warmth and some tingling and whatever else, but I don't feel a hand. So again, it's defining that. People say, well, that's been a bit anal, isn't it? It doesn't matter. Well, I think sometimes it does, because, you know, that kind of thinking can be really helpful for some people, just to perhaps distance themselves a little bit from what's going on, to think clearly about what to do. So continuing to help people to define, to nail down, what are you actually saying here, seems to be really important.
Yeah, and maybe particularly, what are the consequences of what you're saying? So the works by John Weinman, for instance, and Petrie, they've been working on this idea of health beliefs or illness beliefs and they would argue that there are like 5 simple questions you can ask, where what do you think it is, and what is it to you? So what kind of label would you give it? Why did it occur? What do you think will happen to it? What do you think you can do about it? What if it's left, you know, untreated? What can we do about it? What can you do about it? What will happen? So this whole idea about understanding what you believe about your illness really translates well, and it's been done. It's been, you know, it's been implemented directly or indirectly in so many things. Like, for instance, much of the work, so Sam Bonsley's work on Peter Sullivan's concept, and the whole what do they call it? I can't remember the specific name of the theory, but it sort of alludes to the same thing. It's your perceived perceptions of your illness. We just did a study, or 2 students of ours just did a study where they looked into credible explanations. So instead of, so we have a lot of these non-specific pains, you could say, and they look at adolescents with knee pain. That's a quite common problem, and one of these diagnoses could be Osgood-Schlatter disease. Another one could be patellofemoral pain. One where there is identifiable relatable causes of your pain, and one where there's nothing. So basically the diagnosis is clinical. You don't need anything else. How would you give a credible explanation to a patient in their teens to understand what that is without saying you are suffering from patellofemoral pain? So we're not saying we know what's wrong with you. We're saying we know what you need to do about it.
Yeah.
So they did a lit review first, and then they did a Delphi with a lot of people who know about knees and adolescents. And the article is out now, so you can maybe it's only in preview, but you can see the article about it's Chris Jortoft, first author, and Malene Kerbrun was second shared first author, and then Michael Ratliff is last author. You can read it there, but what they came up with independently is exactly the same as John Weinman said. There are certain things that people need to know. So not only could we ask them about it, what do you think? What does it mean to you, and etc. But also, when we try to communicate to you what is going on with you, we could use the same sort of framework to give you a credible explanation of what's going on. So what kind of label could it have? What does it mean for you to have this? Are there things you should and shouldn't do? What can you do about it? Should you be worried? How long will it take? That sort of thing. So I think that was quite eye-opening.
Yeah, absolutely. I mean, those questions and you know, other questions as well. But my feeling is that sometimes, you know, we ask next thing, so there's no detail or depth, or not enough detail and depth. We actually explore what do you mean by that? What do you actually think is going on? Because unless you can understand their positioning on their situation, it's very difficult to be precise, or as precise as we can be, in what we then say, suggest, recommend. So I think that depth and detail through those kinds of questions, and creating the space and the safety, obviously, to do that.
Exactly. Well, I mirror that 100%. I have a metaphor to try and encapsulate that. So again, you would feel comfortable with, I'm not treating the person in front of me. I'm treating my concept of that person. So I think it's knee pain, therefore I will do this, right? Then hopefully the person in front of me will get better when I treat the proxy or the avatar, so to speak, of that person. So my metaphor for that when I teach is that we paint a portrait. So when you sit down and you take your history of the patient and you listen to their story and you ask questions, what I metaphorically am doing is painting a portrait. So imagine you have two people painting a portrait. One is Rembrandt and the other one is Picasso. They're both fabulous artists, right? But when you turn the picture around and say, does this look like you? The Rembrandt, you say, that's amazing. You've really captured me in depth. And when you turn around the Picasso, people are like, that's really weird. I don't think that's me. So imagine you design your treatment on a Picasso, right? That wouldn't work, because you're doing something other than what the person in front of you really is telling you. So I like that metaphor of painting a portrait and then realizing that you need to put effort into making as live a portrait as much, the portrait has to be as much as the person as possible, because essentially it's the portrait you are designing the treatment for.
Yeah, so
And
you've basically got to check your portrait that you've painted with the person to make sure they can go, yeah, that's me, rather than, oh my God, what
I literally do
distortion
that.
is that?
Yeah, not I don't paint a portrait, but I do tell back. So I do give them, I say, okay, I think I understand what's going on. Do you mind if I tell you what I've heard? And then I would repeat the story that is important for my advice, the advice I give, or the coaching I will be supporting them with, or whatever afterwards.
Yeah, I love that. I love that metaphor. I think that really captures the elements there that are so important. That's superb. Listen, we've been chatting for quite a while. I reckon we might need a part 2 and 3. So let's pause it there for now. But where can people follow and find what you're up to?
Yeah, I'm on mh_dk. I'm also on Instagram, although not too frequently. And then obviously I'm on LinkedIn under my name as well. So yeah, and if people are interested in getting access to some of the publications I have, just go to ResearchGate. You can find it there, and then you can request it directly on ResearchGate, and I can forward it straight from the website.
Brilliant. I'll put all those links there, so people can do that. And then what I'll do is I'm going to, because you referred to a number of papers and things, maybe I can grab that list from you and I'll stick that on the show notes as well. Yeah, then people can check it all out. So listen, it's been fantastic. I've really enjoyed that, and so thanks so much for making the time.
Yeah, I hope the next one can be live somewhere in England.
Oh yeah, let's do that. Yeah, that'd be awesome. Yeah.
It's been too long, hasn't it? I mean, COVID and all, and then you guys left the EU and your country is sinking. Well, I guess it would be nice to see England one last time before there's no NHS anymore.
Yeah, it's a lot of head shaking going on. It's not a good situation, but no,
I wish you all
it'd
the
be
best.
great. Yeah, no, fantastic. Let's keep in touch.
Yeah,
Take
absolutely.
care.
You too. Bye.